Giguere is going to be speaking from IGeneX.
Thank you. Okay, yeah, I'm Bob Giguere. I'm with IGeneX. Some of you know who I am. Been around a little while, and I'm going to show you why laboratory medicine has failed in a lot of places, but it's not quite as bad as some of my predecessors spoke today, and where we're going and where we are, especially in New York State. So we're going to overview, we're going to look at the different tests around after we look at a little bit of the spreading, but Dr. Grotto did a wonderful job spreading it out and talking about it. And then we're going to talk, if I have time, about the co-infections that do show up. So, we now know it's a big problem. If you've been listening to anybody before me, you know it is. And it's, of course, spread out. And again, my predecessors in speaking did a nice job on that. You've all seen the CDC map, where it sits today, and those of you in this audience certainly know it's here. So this is our data, and if you throw it, this is from IGeneX just in 2019. Yes, we get thousands of samples from all over the world every year, and this is 2019. And you can see Lyme disease pretty big all over the place, and that's just our data. And actually, if you laid that over the CDC data, our maps almost line up, only ours are a little more involved because they're a little more accurate. So we know about the early Lyme disease cases, those that show up sometimes with a rash, the stiffness in the neck, the slight afternoon temperatures. Once it starts to disseminate out, you're getting the migratory pain, and it's not arthritis. And of course, the neurological issues, we often see that happen in children, and we just addressed a little bit about the cardiac issues. So I'm going to take you right from when you get bite and what goes on in the body. Once you get bit, after the initial bite, what happens is Borrelia burgdorferi sucks in blood. That blood temperature from its host difference activates an automatic change of outer surface protein A to outer surface protein C, and a multiplication of Borrelia from about 500 copies to a little over 100,000 in 24 hours. That's wonderful data from an old friend of mine, trained with me back 100 years ago, but he was doing a lot of the work in the last few years that Willie Burgdorfer had retired from, Tom Schwann, who also just retired from the CDC. But we found out once it gets in, it starts to immediately inject Borrelia burgdorferi into the body, and it forms a cute little bubble of blood under the skin. Well, right under the skin, you've got a first defensive medicine part of your body, of your immune system, and they're called the dendritic cells. And the dendritic cells grab onto this foreign object as they see it in that little bubble. They ingest it and send it out. Now, right away, you get a T-cell response. That's one of your early immune response. And we are working on, and actually we do have a test, but I'm sorry, you people in New York can't use it. And I do have a T-cell response test that actually will go positive 3 days after a tick bite and lasts for about 2 months. Then it goes away completely once we see a B-cell response, because there is an opposite effect by T-cells versus B-cells. And I'm sorry I gotta move fast, but I got a lot of slides, and anyway, I'm from New England, and we like to talk fast. So, later on in the disease, after the B-cell response isn't very good because of a couple cytokines being suppressed, and the immune cascade doesn't work in the host, and now we start to see co-infections arrive. Late in the disease, when the bug comes back out, because it sends out it does a whole bunch of cute things. When it sends out these cute little plasmids and breaks them off, the Borrelia comes back out into the blood system, and when it does, your macrophages then take over the effect that your initial T-cells, dendritic cells had taken up, and they ingest it and form another T-cell, B-cell response. That's often why you'll see late in the disease, we actually do see T-cell response positive in a number of patients because their immune system's already been suppressed. They can't produce a nice, clean IgM. So here is, actually from a guy in Canada, you're going to in a minute see some white things moving across that. That is the blood system of mouse. Those white things are Borrelia burgdorferi. They're using their spirochetal shape to stay ahead of the immune response, and you wonder why your body can't keep up. Okay, this bug is smart, and it moves. Now, we need to arm our mice. That's the problem. Okay? We don't give them enough, but I know they don't grow old enough to be armed, but if we could do that, we'd be in great shape. We wouldn't have this plague that's now upon us. One of the things I want everybody to understand is one of the problems that the guys at the IDSA, which I was at last week, tend to not believe in or read anymore is what is known as quorum sensing. Bacteria have the ability to change their surface proteins over time. Borrelia burgdorferi, I am a molecular guy, has over 126 genes on it. Syphilis has 7. If syphilis can do it, for God's sakes, don't tell me Borrelia can. So it does, and this is the premier article that was originally done by Stevenson et al. Down at University of Kentucky in 2002, showing quorum sensing. Again, that's the ability of a bug to change its outer surface presentation. He showed it right in Borrelia burgdorferi that he had gotten from. So, we need to understand when we order testing what we're looking at, because the bug keeps changing. And as it changes, if you're doing the wrong thing at the wrong time, you're going to definitely get a negative lab test. So early on, as I mentioned, you get a nice quick T cell response, fades off reciprocally to the immune response, B cells start to jump up, and during the early stage of Lyme, from about 4 to 5 weeks, up until maybe a year, you will see a nice IgG-IgM response. The IgM should go away at about 2 months with an IgG climbing through the IgG numbers, as you'll see in this, and you'll have the mid stage, and then in the late stage is when it gets really confusing because the battle is going back and forth, and you can't tell whether the body is now producing antibodies. If it's not producing antibodies because the T-regs are being suppressed, is interleukin 10, interleukin 6, interleukin 2 being affected? All of these players that are going back and forth really confuse the Lyme testing, and that's not an excuse, it's the honest to God truth. So, I always put this one up because I was with Alan McDonald at a medical center in Boston, a very prestigious one. We were invited there, a bunch of us, and Alan was sitting next to me, and he jabbed me when this came up because Paul Mead showed it. That slide on the left is of course, the CDC two-tier criteria that he put up, but the Western blot he put up was IGeneX's. So we always put this up because he stole mine, and I didn't know it, and Alan showed it to me, and now I use theirs. So, you often heard about this. This was just presented. This is the two-tier semi-approach that the FDA has just cleared. It's cleared by Zeus Diagnostics because Zeus produces enough for a bunch of kids. I can warn you that doing a C6 ELISA, sorry about this, Canada, but I did help Andy Levin develop the C6 back in 97 and 98 at MGH. The C6 ELISA works okay in very early Lyme. I didn't find it very profitable, and neither did he in late Lyme. So this protein seems to hide a lot more later in the disease. And they're using a C6, they're using a C10 and a VSLE1, and no, you're going down a path here because it's cheap and it's quick and it doesn't work. So, let's talk about the testing methodologies and why they work and why they don't, and let's just move along. Remember, the serology is the antigens in the body. We're looking for an antibody, the antibody response by the patient to it. And so when you put this test into a tube and you want to test their blood, you're actually looking for the ability of patients to produce antibodies by putting antigens that are specific, hopefully, to that disease in the little tube. Now, I'm not going to talk about ELISA tests because most of them don't work. 40–50% of the time you get the right answer and you saw the flip of the coin, and that's about what you're going to get. And again, I am on a couple of papers back in the 90s at UConn where those test kits were actually developed. So, we know they don't work well. Early in the disease, yeah, I think a C6 ELISA is probably the best thing. There's a company out there that's now longer resistance, Imagen. They did an IgM capture, probably knew about it in Connecticut. Early on, Berardi did a nice job at Yale with it, but I'm not overly excited about any of the ELISAs out there now. Here is a Western blot. What a Western blot is a piece of Jell-O. What we do is, or any manufacturer does, is a vat. You take this vat of Jell-O, you throw in all the antigens you want to look for, you mix them all up so they're nice and homogeneous. Take the monster, put it up, that little Jell-O thing in the mold in between 2 pieces of glass, put down 6–8 slots down it, and pipette in the human serum at the top. When you do that and you hit it with a positive charge, you will drive the antibodies that are hopefully in that patient's samples, from be they in lanes 2 through 9 in this case, or 1 through 9. And what you will do is drive the Borrelia, hopefully antibodies, in that patient down through the bodies of this this wonderful piece of jello, turn off the power, and let nature take its course, where the antibodies that you spread by molecular weight bind to the antigens that are homogeneously spread. They form cute little immune complexes, hit it with a photographic plate, and you've got a glowing, wonderful band. And that's what the bands are. They're the presence of antibodies to specific diseases, antigens, that are expressed as KDA, that's the molecular weights. So, since I got involved in this wonderful plague since 1991, we now know that there are all of these different antigens that we think are the right size antibodies to be part of Lyme. But we've also found over the years that many of them are not specific for Lyme disease, especially when you're using whole cell antibodies or proteins. They just don't, their specificity drops off. And of course, there is some in here that aren't allowed by the CDC, by the kits that are used, and of course aren't always available. Now, how smart is this bug? Well, here is in living color, and this one's going to show you Borrelia in green, actually using the spirochetal shape to bore out of the blood vessel. So now it's using that shape and it's going back and forth, and in a minute, all of a sudden, his buddies are still trying to outrun the immune response, but he's smarter than that. He's going in the tissue to hide. So he's going to go in the tissue, he's going to form a cyst, and you're never going to see him again. Good luck treating him. Okay, I'm going to talk to you not about Western blot so much, but now our new testing, because we do think this is better, and so does New York State. It took New York State and the CDC less than 2 months to approve our immunoblots, because this test is far and beyond anything else we've been able to develop and use in the United States. And now New York State, which is one of the toughest places in the world to get anything approved, has approved it. For your own information, I've still got tests that we've submitted 10 years ago to the up to Albany to try to get approved, and they're not there, but this one is. Why? Now what we've done is we've taken recombinant proteins that are DNA specific to all of the sensu lato strains of Lyme. So that means the European strains, the American strains, even the one from Australia, yeah, we're picking it up. And they are very, very specific. How specific? We had to take, if you can see that band 23 and 31, each of the sensu lato strains have minor, significant though, differences between each other in all these strains. So we actually put them on, each of them, on this blot when we put it there. So if you've got Ifseli, if you've got Guarini from Europe, because you wanted to travel there, or you went somewhere else to play, we're going to pick it up, and we're not going to miss it. It's not going to be a false positive. It's not coming from Epstein-Barr. It's not coming from chlamydia. Please don't tell me it is, because I'm a molecular guy, and DNA is DNA is DNA. Okay? So how good is it? According to New York State Department of Health, our immunoblot for sensitivity has 98%, and our specificity is 96.7. You don't get better than that in immunology. And of course, this is a comparison against our Western blot, and it just shows that, again, even with the Mayoni and the California strains, the Mayoni was named after the Mayo. They published in New England Journal of Medicine 3 years ago, or 4 years, and found it. I called my friend at the CDC, asked them how many patients had Mayoni, and they said, oh, the 6 that they published on. That's the only ones they could find on 20,000 samples. But we've seen a big jump in that now that we're doing immunoblots. In the Midwest, Wisconsin, and into Minnesota, we are seeing a significantly growth in the Mayoni strain. It's one of the sensu lato strains of Lyme. So, should you include PCR? Here's the problem. Not everybody, as you heard earlier, converts. They get this bug in them, they get the 1 day of antibiotic, or 2 days, thank you, Gary Wormser, and then all of a sudden they don't convert, and we never get a positive serology, and so you're never going to get a positive test. Again, that's where PCR often plays out well, because if you don't have seroconversion, the bug's going to hang around, stay in the blood, and with luck, we're going to pick it up. And in our studies so far, you get about 12% more positive rates when you do a PCR along with our immunoblots. And of course, these are the pathogens that we worry about now for tick-borne pathogens for PCR, and I'm going to talk to you about the new plague. The new plague is called tick-borne relapsing fever. You've heard a little bit of a dance about it. The biggest strain we've got in this area right now is Hermsii. To your north and to your west, we are picking up Borrelia, Hermsii rather, and here, it's Miyamotoi. Borrelia miyamotoi was published on by Peter Krause out of Yale 5 or 6 years ago. Yes, it's named after a Chinese guy, but he actually discovered it in Russia about 20 years ago now. And we've got a number of strains that look like, feel like, taste like Lyme, and they're not. It's called tick-borne relapsing fever. How much is it? Well, it's pretty well spread out. I actually had, when my friend did retire from up there at the CDC, I went out to see him, and then I had to go give rounds or talk down the road in Boulder. And when I did, the number of physicians in there had never heard of Borrelia hermsii, yet the day before, the head of bacteriology had showed me a slide where Borrelia hermsii is epidemic west of the Mississippi. And how fast is it transferred? It's in a solid, it's in a bug called Orthodontus hermsii, and it's transferred in about an hour by people who like to go camping in the mountains. So if you go overnight in the mountains, this is where this bug lives. It comes out, it lands on a person at night, and it gets off an hour later, and so you go home with a lot more than pretty pictures. Okay? So you gotta be real careful of it. The Miyamotoi strain is catching on, and the biggest problem we've got with Miyamotoi is its ability to spread. As you heard earlier, a tick will lay about 1,500 or 2,000 eggs, and none of them carry Borrelia. Well, guess what? They carry Miyamotoi. But at least 60% of the larva coming out of a mother that has Miyamotoi is going to be carrying this strain. So we have seen a huge increase. I was at the vector lab up at the University of Maine about 6 months ago. 2 years ago, they didn't find any. This past year, they found 16% of the ticks they were testing, especially they are picking up Lone Starry up there, the Lone Star tick rather. We're seeing this explode. You're going to see it explode if you haven't already. And if you're testing for Lyme disease, you're going to miss it. And of course, this is what Peter Krause said back in his New England Journal of Medicine. This is Brian Fallon's statement underneath it. And the truth of the matter is they're absolutely right. Bugs being missed. So when we do tick-borne relapsing fever, all of a sudden the positivity rate goes up when we add that in, especially to people who've had a seronegative or not composited with our regular immunobloods. So let's get into the co-infections, because this monster does carry at least 16 different bugs that the CDC has found on Borrelia in the different ticks, the 6 different strains of the different types of ticks rather that are here in the United States. And Babesia is the biggest one, the one that scares me the most. Here we have Duncani, not just McCarty. And that's very important for you people to know who want to go to your doctor, because you've got a global headache, you've got a pounding one, you're having night sweats every 4 or 5 days, you're profoundly tired. And you go in and he goes, gee, maybe this is Babesia. And he's going to test McCarty, because that's what Quest, LabCorp, and everybody does. I can assure you these slides they use, which is an IFA test that I didn't go into, will not cross over and pick up both strains. So you could walk away with Babesia and have Duncani, which is actually a more virulent one. We're finding treatment protocols, and I hope the good doctor after me, Ligner, will much more versed in how to treat it. But I'm warning you that you need to test for both Duncani and McCarty, and yeah, IGeneX is licensed in New York State to do them both. And we've actually got a fluorescent in situ hybridization test for it, so that the doctor that tries to tell you, oh my God, it's DNA, but that doesn't mean anything. Well, I got a FISH test, which is called RNA. RNA is active live bug, and if you went to med school in the last 40 or 50 years, you know how to spell RNA, and somebody told you, gee, that's a live bug. Yeah, we've got the FISH test that's allowed in New York and everywhere else in the United States. So, what are the causes? All over the place. Again, PCR is a wonderful tool for this. When you get a positive, it usually means there's DNA in it. You know, I did help a guy named Henry Lee and a couple guys down in Quantico build their DNA labs 100 years back in the 1980s. But it's true there, it's true here. When you find the DNA of somebody or something in a certain place, it's been there. If it's not still there, it definitely was. And so FISH testing is a nice step up, because it gives us much more RNA usually around. And if you can get a doctor who knows how to read a malaria smear, that might be a great way to get the infectious disease guys involved, because they usually believe the pathologist, at least before they both go off to play golf. And the indirect test, as I mentioned before, I'm going to tell you to stick with the Duncani and the McCarty both if you're going to do an IFA, because nobody does a good Western blot, and certainly the ELISAs are a joke. So These are the tests of our fish technology, and it just shows that we are able to pick up a significant higher number of Babesia. Babesia has a nasty habit of going after an interleukin called 6. When it does that, these two interleukins, that one with Lyme disease, starts to suppress the immune system automatically. When that happens, your T regulatory cells, which are trying to keep your pro-inflammatories up there, start to degenerate down too. So you're dropping down the person's immune system, and when you got both these bugs in there, they're working real hard to congenitate together, and they're decimating the patient's immune system. So you got to try to get the Babesia, and of course, Babesia deaths are well recognized. So one of the co-infections no one pays attention to, and it was mentioned earlier, and I want you to start thinking about this, even though we have a new test that works for Bartonella that you people in New York can't have, and it's called the Bartonella Western blot. But there are at least 4 strains of Bartonella in the United States, and you will get a Quintani or Henselay, depending on whether you use Quest or LabCorp, and they'll miss the other strains. So you're going to have a problem. You've got to go to a Lyme literate doctor, like the doctor who's following me, and see Dr. Ligner and have him make a clinical diagnosis. Then you'll order the tests that are available. We do have a Bartonella IFA that is available here. Most of the IFAs, even ours, are fair at best, not great, and they don't pick up all the strains. Our Western blot, unfortunately, you people, it is, and yeah, we're seeing a lot of it. The Elizabethan is in the Southwest, and we're picking up all of the major strains. The Bartonella infection usually includes burning hands and feet. We often see people who are having sensitivity to the light, and they often have tender skin nodules behind them, or what we call is cat scratch fever, which is that beautiful little, look like straight-edged rash behind your arms, on your lower back or behind your knees. But of course, your primary care doctor has to practice 7-minute medicine. He doesn't have time to look at you, so they're going to miss it for sure. So we have a Bartonella fish. Sorry, you guys can't have it in New York. It is before them. They are looking at it. We are working diligently with not only the CDC, but with New York State Department of Public Health to try to get more of these tests approved. When they do it, it becomes the gold stamp of approval. A New York State approval test. We have more tests approved in New York State for Lyme and its co-infections than anybody in the world. And we did that because we do it right, we do the science, we take our time, and we get the data down on accurate testing. So this is our Western blot that I'm sorry you can't have. But it does pick up 4 of the major strains, all of them in the United States. And then there's only one other co-infection I'm going to bounce through, and that's Anaplasma ehrlichia. The good news is you don't need IGeneX for this. Every laboratory does a robust test, and the IFAs for either of these, done by Quest, LabCorp, or your hospital, are usually very good. So here you can see the spread of Anaplasma ehrlichia, and again, most doctors like to see this. Patient has a headache that's right behind their eyes. We often see that as one of the major symptoms. I'm sure Dr. Ligner has far more expertise than that. So the testing for it, we do have a PCR, but the ELISA assays seem to work real well, not just from IGeneX, but from other people. So the distribution of the key ticks, as you can tell, this is our latest data from 2019. Again, we're doing thousands of samples. And, oh, God, I moved much faster than I thought I was going to. So look, Judson Shabbat, the laboratory, she's a Harvard-trained lady. I tried to hire when I was outside UConn, and Nick stole her from me. She wanted to work in Palo Alto instead of in Farmington, Connecticut. I can't believe it. But she's in charge, and we are CLIA, CMS licensed and certified. We receive samples from all over the world, and we do it every day, and we try to do it better than anybody else. So if there's no other takeaway message is that the most dangerous test result is that false negative, and I got to thank the people up in Calgary who had nothing other to do than to inject their mice with things so that I could see them in those videos. Thank you, Dr. Karchachos. Okay, so I'm done. That was great. I flew through it. Nobody gave me any hard time. This is like